Welcome to Module 4. In this module, we'll talk about mechanical ventilation, first in patients with ARDS and then in patients with increased airway resistance, such as those with asthma and COPD. We'll focus on the assessment and management of these conditions to what pertains to mechanical ventilation. We will not discuss pharmacological interventions such as sedation, paralysis, pulmonary vasodilators, steroids, bronchodilators, and so forth. An important disclaimer that I'd like to make is that many of the concepts I'll discuss in this module are theoretical or based on early experimental data. Even though a certain intervention may make sense, that only means that according to our mental models of pulmonary physiology, that intervention should be helpful. The reality, though, is that even the mental models of the most experienced researchers in ARDS are orders of magnitude less complex than biological systems. Medical history has countless examples of widely accepted practices that made sense, which were later proven to be harmful once rigorously studied in trials. So please exercise sound clinical judgment in how you incorporate what we learn here into your practice. Although I will try to offer some guidance and will occasionally mention a key study or a meta-analysis, an extensive review of the literature is outside of the scope of this course. Let's get started. The acute respiratory distress syndrome is characterized by the presence of inflammatory non-cardiogenic pulmonary edema leading to hypoxia and bilateral infiltrates on chest imaging that is secondary to a recent major insult, whether pulmonary, such as aspiration pneumonitis, or extrapulmonary, such as acute pancreatitis. We can't talk about mechanical ventilation in ARDS without discussing ventilator-induced lung injury, or VILI. Although mechanical ventilation is essential to keep ARDS patients alive, it also has the potential to worsen injury to the already diseased lungs. The crucial role that VILI has on patient outcomes is so firmly established that it drives some of the key principles of mechanical ventilation in ARDS. So we'll spend some time discussing it today. Decades ago, VILI was thought to be the simple macroscopic disruption of lung tissue, leading to pneumothorax or pneumomediastinum. Our appreciation of VILI evolved to a much more complex understanding that mechanical ventilation leads to a more diffuse, microscopic injury at a cellular and structural parenchymal levels, leading to an inflammatory response that has likely even systemic consequences. Extensive data from several animal models try to elucidate how mechanical ventilation induced or aggravated lung injury. Proposed mechanisms of injury were clustered into two groups: lung injury happening at high and low lung volumes. Several experiments consistently showed that ventilating mammals with high airway pressures and high volumes led to either new injury or further damage to previously diseased lungs. This lung injury was characterized by disruption of the alveolar capillary barrier and development of inflammatory pulmonary edema. Why do we call this process valve trauma instead of simply barrier trauma? A series of studies show that lung injury could be abolished by limiting tidal volumes for the same levels of applied pressure. By strapping the chest on animals, for example, the same high levels of applied pressure now only generated small tidal volumes. The effect was prevention of VILI. The mechanistic explanation is that we limited lung overdistension, which can be looked at from two different angles. One angle is that we have reduced tidal volumes. The other angle is that by decreasing chest wall compliance, pleural pressures rose remarkably, reducing the true lung distending or transpulmonary pressure. In the second set of experiments, large tidal volumes were also shown to lead to lung injury, even in the absence of positive pressure ventilation. Now, large tidal volumes were generated by negative pressure ventilation through an iron lung. The negative pressure outside the chest is transmitted to the pleural space, again raising transpulmonary pressures. These experiments show that high pressures are neither required nor sufficient to cause lung injury. Volume trauma is caused by lung overdistension. Other experiments have shown that the state of inflation of the lungs prior to receipt of tidal volumes influence the degree of lung injury. Edematous, injured lungs tend to collapse during expiration. If lung tissue is collapsed, it will be stretched open with every inspiration and again collapse during expiration. This cyclic opening and closing of alveoli, named atelectatic trauma, is thought to lead to villi at low lung volumes. So ideally, we would avoid low expiratory volumes to avoid low collapse. But how can we control expiratory lung volumes? Well, with PEEP. Remember, total PEEP is the end-expiratory alveolar pressure. The higher PEEP we use, the more inflated our lungs are before tidal volume delivery. These observations paved the path for human studies which culminated in the ARDS trial, published in the year 2000. This study changed our paradigm of mechanical ventilation in ARDS after showing that a ventilation strategy focused on avoiding villi by reducing tidal volumes and aiming for lower plateau pressures improved mortality even though gas exchange was worse early on. The message was clear: minimizing villi is more important than attaining normal gas exchange. This is it for our introduction to mechanical ventilation in ARDS. Now that we understand the importance of villi and the mechanisms behind it, we will explore the different key components of lung protective ventilation, including titration of tidal volume, PEEP, and more. This will be an incredibly exciting part of our course. I'll see you next week.